The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. In today's podcast, we're going to dive into all things toxicity and look at one of the worst overdoses that you can have from a complexity standpoint and talk about aspirin overdose. Our patients nowadays have multiple medications, that polypharmacy per se. Very easy for them to mix up medications or maybe not understand as we get older that certain substances may have aspirin in it. And we're going to look at a few of those as we progress through the talk, but the key is we could have ingestions. A lot of these aspirin overdoses are unintentional. Obviously, we do have a small subset of patients that have intentional ingestion. And so really, it comes down to understanding what type of ingestion, and really, do you know there was an ingestion? Is the patient forthcoming in an intentional overdose, or is it an unintentional overdose and they have no clue? We're going to start with a case. We have a 33-year-old female patient. As you can see here, she's just not feeling well. She's very achy. Husband comes in and just, she says, I just don't feel right. I don't feel good. I'm achy. And so we're just going to chalk this up as a general illness. When we look at this from a more expansive overview, she does have a history of polysubstance abuse, a history over the last 5 years of depression, and has had anxiety since she was a teenager. So husband says, hey, let's go to the ED. She is brought to the ED by her husband, and they arrive. So let's dive in more to this overall case study, but we're going to intertwine the case study with assessment pearls, pathophysiology, and treatment, and then we'll move all the way through to a final reassessment at the very end. What is aspirin? Aspirin is acetyl salicylic acid. We know it then breaks down into salicylic acid. And we see this given really in those cardiac patients. We see that as a preventive measure in patients that have had cardiac history. We also give this in our line of work for those MI patients. And we know our patients might take one simple baby aspirin, or they might take multiple. We usually give 4 of those 81 milligram tablets, 324 milligrams, but really the action is to decrease platelet aggregation. But I don't think really mainstream population understands how dangerous this medication is. And studies have shown that really if it's used outside of the cardiac realm, patients with cardiac history, there might be some subsets with clotting disorders. I have myself a clotting disorder called factor V Leiden deficiency, and much more of a serious situation for females, especially if they're pregnant, taking birth control. But, I could take a baby aspirin every day. It's not really a mandatory thing. So you might see certain patients take aspirin for different reasons, but really outside of those reasons, it's not advisable. When we think about aspirin from a home medication, I know in our medicine cabinet, we don't have a bottle of aspirin that I know of. But do you have Pepto-Bismol in your cabinet? And do you understand that there's a huge concentration of aspirin within Pepto-Bismol? You have GI issues and you take Pepto-Bismol and you drink enough of that, you could become toxic. Another one is oil of wintergreen. Every ml of oil of wintergreen has 1.4 grams of aspirin. So that's a huge amount. And again, if you don't know this, you could definitely have an unintentional toxicity. We come back to our case. They do an assessment when she arrives in the ED. She is anxious. They note she's tachycardic and tachypnic, breathing very rapidly. Neuro exam shows that she's agitated, really grumpy, almost appears to be intoxicated. They say she has an altered mentation, but we'll say that she has a Glasgow Coma scale of, we'll say 13 or 14. She is notably diaphoretic, and she has vomited once since she arrived. They do a temperature tympanically, and it's 38.3 degrees Celsius. They order labs and ABG, and really the ongoing assessment starts. If we come back to our aspirin dosing and we look at, well, what is a normal therapeutic range? Have to understand the foundation before we move into those toxic levels. That range is 10 to 30 milligrams per deciliter. And we know the absorption for aspirin is, 10 to 15 minutes first pass metabolism, meaning it has to, move through the gut and absorb through the gut, and then it moves through the liver. But the half-life, as you can see, is very, very long. You can have half-lives based on dosing of greater than 20 hours. And so when you think about aspirin ingestion, you always have to have a high index of suspicion. It is never wrong to give activated charcoal even 3-4 hours after ingestion, because the release in the stomach often can be very delayed, and your initial serial aspirin levels are going to be lower than really maybe the levels within their body. And so you need to do serial labs, serial aspirin levels, really up to or past that 6-hour mark, and continuously reassess your patient. And so based on that assessment, when we look at assessment, we have to understand the concept of cognitive bias, or what we at FlightBridgeED labeled as second fracture. And what does that mean? Well, how is this patient presenting? If we go back and look at how she's presenting, does this mimic something else? And I think cognitive bias really comes down to a multitude of things. Do we have outside stimulus that kind of guides us down the wrong path? Do we have a family member that tells us one thing, they don't really understand the full story? Or is another practitioner, a provider, a physician telling you something that makes you build a story in your head? And so we can easily become skewed. Is it based on your past experience? Do you have a lot of experience? Sometimes that's the worst thing. Are you complacent? Lots of examples of cognitive bias where we miss the big thing. We see something right in front of us, but we miss really the elephant in the room. And so if we evaluate her from that perspective, right, she has an altered mentation, Glasgow Coma scale of 13, 14. When we think about her fever, all right, well, what causes a fever? What causes altered mentation? She is breathing rapidly. She's tachypnic. That doesn't really make a lot of sense from the standpoint of just her age, right? That usually kind of goes down the standpoint of a sympathetic response and hypoxemia. She's diaphoretic. Why is she diaphoretic? Why is she febrile? And lastly, she's tachycardic. So based on those 5 areas, where does that lead us? Well, it leads us down the SIRS response. And we know that when we think about sepsis, we know that we just look at SIRS and then it's classified as sepsis and septic shock. Severe sepsis has been removed. But if you think about her presentation, she has a heart rate greater than 90. Her respiratory rate is greater than 20. Her temp is greater than 38 degrees Celsius. The only thing she doesn't have really is the white count. And when you look at the sepsis evidence, the number one factor in really identifying if a patient is declining is getting worse. If you look at all vital signs, you look at all those things, it is a respiratory rate that is high. A high respiratory rate is really, really predictive. So what do we do with this? If a lot of these patients are unintentional ingestions, are you going to even have an aspirin level? A lot of times the treatment starts being focused on a sepsis type response. And then if you're not aware, that's where a lot of these patients end up becoming extremely sick. That toxicity increases. That absorption obviously is slow, but if you're slow to recognize it, that's where you get into trouble. So even if a physician, a nurse practitioner, a PA is going to ask for a tox screen, the aspirin level is not going to be part of that, and that has to be requested outside of a standard tox screen. So what is that lethal range? What is the lethal dose? We know a normal therapeutic dose is that 10 to 30 milligrams per deciliter. And really, this is going to be based on multiple different sources, but a non-lethal dose, you could say, is anything less than 150 milligrams per kilo. So if you used an 80 kilo patient, for example, multiplied by 150 milligrams, that's 12 grams of aspirin or 148 pills. What if we looked at this from the mild to severe toxicity? So we'll just say anything greater than 150 milligrams per kilo. And some sources will actually list 150 milligrams per kilo or greater as a potential lethal dose. So this is being a little bit more specific. You definitely would say anything greater than 500 milligrams per kilo is a lethal dose. And so just for example, if you had an 80 kilo patient and they took 500 milligrams per kilo of aspirin, that's 40 grams, or really we'll say one bottle of bare aspirin. That is a lethal toxicity. But this is going to be based on past medical history, comorbids. It's going to be based on age. It's going to be based on time of recognition, the level of treatment, the level of understanding by the providers of aspirin overdose, pathophysiology. There are so many factors that really play into how these patients will do. So what are the clues, right? We go back to her presentation and we saw that she was tachypnic, she was tachycardic, she was febrile, she was diaphoretic. What are some clues that are going to guide us? Well, one of the big clues that we really have to understand is the tachypnea. The tachypnea in a normal patient, and we're going to break this down, should be in response to a hypoxemia. That is our normal body's response. When we become hypoxic, we see a sympathetic response, and that increases our minute ventilation in an attempt to move more gas through our lungs. But if you have any type of EQ mismatch, again, we'll break that down, then that we know does not help the situation. So we have to be able to evaluate our PaO2, look at an ABG, and evaluate what do we have? Are we hypoxemic or not? What's the tachypnea doing? Why is this patient breathing that fast? And so a few ways, if you have point of care testing, you have an EPOC, you have an iStat machine, you can definitely get serial ABGs or venous gases. But you at the bedside can simply do what's called a calculated PaO2. There's two ways. This is a maybe a little bit more specific way. You're going to take an atmospheric pressure that's average. So 700 millimeters of mercury is a fixed number. You're never going to change that number. Multiply that by 0.50. So if we, for example, 700 times 50% FiO2, 0.50, that's going to be 350. Subtract 50 from that. We have a PaO2, bedside PaO2 of 300. Another simple way, it's much quicker, is to take whatever FiO2 they have and simply multiply it by 5. So 50% FiO2 in this example, they would have a bedside PaO2 just using that simplistic way of 250. So there's a 50-point difference there. The point is to get an understanding, right? We can't be so black and white. We have to, again, work outside of that black and white thought process. We got to have 50 shades of gray and understand, okay, it gives me, whether I'm 250 or 300 as my starting number, it gives me an understanding of what this patient is doing. Why is this patient tachypnic? What does my SpO2 show? Right? There's a lot of factors that drive what that SpO2 is, but until we understand the big picture, that SpO2 is a reflection of the oxyhemoglobin curve and how hemoglobin is either being released or held on to. So a lot of different things to really take into consideration, but really the tachypnea without hypoxia is the key. So the labs come back. Notice we have an aspirin level of 99.4. We're definitely above that therapeutic range, and that's at the 2-hour mark. If we look at this ABG, there's a couple of things. Let's go right to the PaO2, and notice we're at 98. So we have no hypoxemia from that standpoint. I would also want to see an SaO2. But from just these numbers, we know that this patient falls in that normal range. But if we were to look at this pH specifically and break this down, I use the first and last name mnemonic. So I know that if it's less than 7.35, I am uncompensated. If it's greater than 7.45, it's uncompensated. So I know I have an uncompensated pH. And if it's less than 7.4, I know I'm acidotic. So just based on the pH, I'm an uncompensated acidosis. I like to go to the bicarb first. I want to know if the kidneys are involved. What is my bicarb level? And I know a normal range is 22 to 26. If I have more bicarb, more base, then that number is going to be greater than 26. If I have less base, that means I have more acid. And that's exactly what we have here. We have a reflection of acidemia. So I could say, all right, I have an uncompensated metabolic acidosis. The last thing we have to look at, though, is what is our respiratory side doing? And we know that based on standard buffering, our respiratory side is really the last line of defense when it comes to us being ill. It can respond very, very quickly. And the way it does that is it recognizes, hey, we have all these protons floating around. We've got all this hydrogen floating around. We also have all this bicarb floating around. And why is that important? Because bicarb, guys, is just a simple CO2 transporter or CO2 carrier. That's all it is. And so the majority of CO2 is bound to bicarb. The more acid production we have, the more inability we have to get rid of that CO2. We're going to carry more and more within our bicarb or on our bicarb. And so the lungs recognize that and they say, okay, well, let's get rid of this. And so we bind hydrogen, we bind bicarb together. It forms carbonic acid. Carbonic acid then will move and split apart into CO2, which can be exhaled. That's the whole point of this. The lungs want to get rid of that, and the water is then evaporated. And so that's what's happening to this patient. This patient is in a partially compensated metabolic acidosis, because what we have to understand is if the kidneys are showing acidemia, our body's normal response is to have the respiratory side move opposite. The kidneys are showing acidemia, the respiratory side is going to show alkalosis. And that's exactly what we have. So we change the ABG from an uncompensated to a partially compensated metabolic acidosis. And it's all about the CO2 being alkalotic. And then we have a base excess of -18. Not going to get into and break that down in this lecture. If you want more about that, I did a lecture on the metabolic nightmare, and I really break down the base deficit and really everything that goes into it, or a base excess or base deficit, right? We talk about what the different terminology is and why. Lastly, though, we have an anion gap of 24, and the anion gap is a indicator of acidemia. Can be an indicator in certain rare circumstances in an alkalosis. But really what we teach is we're looking for acidemia. And so we can do this in a corrected or uncorrected version. It's always probably best to do a corrected version. That's using the sodium and the chloride and the bicarb, which remember on a Chem 7, Chem 8 panel, that bicarb is reflected as CO2 because it's serum bicarb. And the last factor in a corrected is that potassium. So we know the more acidotic we become, the more hydrogen shifts into the cell, which kicks out the dominant intracellular cation, which is potassium. That potassium then gets shifted out of the cell into the extracellular volume compartment. And that's where our lab is really measuring. It's measuring solute versus solution. And so your K will rise because of that acidemia. So it makes sense that that K is a true reflection of just that. Based on the acid-base progression, we know she's tachypnic. We know she is not hypoxic. So in most cases, the initial ABG, if you were to look at an ABG in that initial shock state for the majority of patients, you're going to probably find them in that respiratory alkalosis. It's going to be uncompensated. And in her case, because again, this tachypnea has nothing to do with hypoxemia, she is not going to be hypoxic. And then we see it progress into a lot of times that partially compensated metabolic acidosis. And that's what we see with her ABG right now. Now, we're going to break that down, but that ABG is her initial ABG. That is a very ominous situation, right? We're going to talk about why that is, what we need to do to correct that, because that needs to be corrected. And lastly, these patients end up in a metabolic alkalosis. Now, again, we're going to talk about treatment. We're going to talk about why we want to drive that actual pH towards an alkalotic range. And there's important reasons why we do that. But what is the pathophysiology? The pathophysiology is just massive when it comes to aspirin overdose patients. And so we're going to dive into and look at really everything that's going on with this patient that we have to be able to either identify. Some of these things we just need to assess. Some of these things we need to treat. It starts with what we just talked about, tachypnea, right? Why is she tachypnic? A lot of these patients will have ringing in the ears. She is hyperthermic. She has a fever. Why does she have a fever? She's vomited. How does that vomiting play into how she declines, how these aspirin overdose patients get worse? We saw 3 different acid-base arrangements. And so this is multifactorial. That can be very complex. These patients end up having really some insult in the cerebral hemispheres, and they end up being neuroglycopenic. And that is just the sugar inside the brain is depleted. And so we'll talk about that. They become altered. Well, why do they become altered? Is it because of that neuroglycopenia? At some point, they start moving towards a hypo-K state. And so we're going to talk about why that is. If she is acidotic, and I just went through the whole aspects of hydrogen shifting into the cell, K shifting out, and that hyperkalemia ensuing, why would she be hypokalemic? You have a process of uncoupling of oxidative phosphorylation. If that term is new to you, that is essentially the electron transport chain. It's the process of making ATP in aerobic respiration. And so if we have uncoupling of that process, you can imagine our ATP production is really reduced. And all of these patients have significant volume loss. They could have 3 to 6 liters of volume loss when they arrive in the ED. When you do labs, these patients often will show a hypernatremic sodium. The thing about this, though, that's super important is to understand this is most often a pseudo number. And so when you really look at the patient, their total sodium level is dropping. As you can see, it is super complex. So let's dive into each one of these. We know, as we said with our sepsis patients, most of these sepsis patients become tachypnic. Really, any sympathetic response, our body's response is going to increase our respiratory rate, increase our minute ventilation, dilate our pupils, increase our heart rate. Our blood pressure goes up, right? That's that initial response. And that tachypnea in that normal response is often due to a hypoxic issue. And so this is usually based on a surge response, right? We have a problem. We come into the ED, the hospital. Maybe you had an elective surgery. Maybe you come in multi-systems trauma patient. But our body a lot of times will attack itself. We have this big inflammatory response. And so imagine that inflammatory response hitting the areas of our lungs. And you have leukocytes and macrophages and cytokines that start breaking down the endothelial lining that surrounds our alveoli and our capillary beds. That lining is lined with these little hair-like projections, these little cilia called an endothelial glycocalyx. And imagine walking out in your yard and you start pulling grass. That's essentially what is happening is you start having these holes in and around the alveoli in the capillary bed, and you have basically fluid leak. And that fluid ends up pushing apart the alveoli and capillary. That gradient widens. That fluid enters into the alveoli. That disrupts the normal surfactant to water ratio. And you have a very poor ability to have gas, i.e. oxygen, moving from our environment down our bronchioles, ultimately to reach our alveoli and cross that capillary membrane to hopefully reach a red blood cell and attach to a hemoglobin. And so when we think about that, that is called a VQ mismatch. And really V and Q, V is minute ventilation, right? Normal minute ventilation for any adult patient is 4 to 8 liters per minute. You could even say kids, right? They probably fall on a different plane within that 4 to 8. And then cardiac output is also 4 to 8. And the average adult falls right around 5 to 6 liters a minute ventilation and 5 to 6 liters of cardiac output. But our lungs get an equality. They get equal ventilation, equal perfusion. And so usually in this case, because we're talking about hypoxemia, you have a minute ventilation issue, right? We're not getting gas ultimately to land on that red blood cell in the solution. And that comes back to the solubility of the gas. The oxygen cannot move through and get into that solution, the capillary blood. We call that a venous admixture. And that just means that, if we identify this early, you can usually get in front of this, right? We can start giving more oxygen, increase our FiO2. We can add some PEEP, which increases surface area, and we can apply pressure in a couple ways, right? By increasing FiO2, you're applying more partial pressure. You're increasing the environmental pressure that's normally there and raising that up significantly. So that adds pressure. And we can obviously put the patient on those devices. It could be simply a nasal cannula. It could be an on-breather. It could be a bag valve mask. It could be bi-level ventilation, right? But what we do is we're putting pressure behind the gas. And these patients will hopefully respond. But that's why they're tachypnic. That's a normal response. Well, we got to go down a different pathway, right? That road really is closed in this type of patient. And we have to understand that aspirin overdose progression is much different. We got to change our mindset and take a detour. And so what is the progression? Aspirin's progression is really that salicylic acid stimulates that medulla, and that medulla is going to cause that tachypnia. That's the key. It has nothing to do with the lungs, hypoxemia whatsoever. Ultimately, there's no hypoxia, and that really needs to be one of those little pearls you put in your back pocket or your tool bag to recognize, hey, why is my patient tachypnic? That tachypnia is really, again, based on that medulla. That medulla is the respiratory cardiac centers in our brain. That's also why they're tachycardic. But that salicylic acid is neurotoxic, and that's where we start seeing the stimulation in the cerebral hemispheres, or we should say the midbrain in that medulla. And then that leads us to, okay, well, if we're stimulating the brain, it stimulates really and causes that phenomenon we talked about in the pathophysiology slide of neuroglycopenia. And so your patient has an altermentation. Our standard approach is always to check a capillary blood glucose. And you're going to do that, and it's going to be normal. And you're going to scratch your head and go, well, what's wrong with this patient? This is an example where it has nothing to do with the capillary blood glucose. It's cerebral glucose. That cerebrum is hypoglycemic. And so we need to treat that. We need to give them some sugar, and they will respond. As we said, we have to understand that we need ATP for cellular function. And so there are multiple substances or gases out there that will cause a phenomenon called uncoupling of oxidative phosphorylation. And I'm going to break this down. I think it's important for us to understand this concept. But that essentially causes a reduction in ATP production. And it really causes an increase in hydrogen that's not being utilized for ATP production, because all hydrogen that gets moved into this area, this intermembrane space that I'm going to show you, contributes to 1 ATP. So every hydrogen contributes to 1 ATP. Well, aspirin does something really weird, and it removes that hydrogen from that space and moves it back down into the myocardial matrix where it can't contribute, and it has to dissipate. It's got to get, the energy has to be released, and so it gets released as basically a thermodynamic response, and that's what causes the fever. Now let's look at what happens in oxidative phosphorylation. Remember those NADHs, the niacin, and the FADHs, the riboflavin, and the hydrogen bonds. Those hydrogen bonds are super essential. Got to get rid of those hydrogen. Those are acids, those are protons, and so we have to be able to get rid of those, and that is the key with breathing oxygen. 95% of oxygen is all about binding with those hydrogens and forming H2O. But how does this facilitate ATP production? Really happens in this electron transport chain. So those niacin, those riboflavin, they enter into this myocardial matrix, this area at the very bottom. And what you're going to see is 6 NADHs and 2 FADHs enter into this area. The first part of this electron transport chain is this pink area called complex 1. And then you have complex 2, you have coenzyme Q, complex 3, cytochrome C oxidase, and lastly complex 4, with a final piece all the way to the far right, we have ATP synthesis, and sometimes that is called complex 5. So the whole key here is the NADHs, the niacin with hydrogen bonds. It needs to release its electrons and release those hydrogens. And so that's exactly what's going to happen. The NADHs release the electrons into complex 1. So notice those 2 electrons are released, they move into complex 1, and hydrogens are then offloaded, and we end up with NAD+. Now we have the 2 FADHs that are in play. They're again in the mitochondrial matrix, and notice it is right below complex 2. The same thing is going to happen. It actually releases its electrons specifically in complex 2. And so you're going to see those 2 electrons become released, moving into complex 2, and those hydrogens again are now charging this myocardial matrix area. And as a result, we end up with 2 of those FADs, those riboflavin, plus 1 hydrogen. So what's the point of this? Well, the point of this is to move electrons through these complexes. And as they move up through the complexes towards the inner membrane space, I want you to imagine it energizing those complexes. And when it energizes the complex, it opens these gates up. And those gates are going to allow for hydrogen to move through from the mitochondrial matrix up through that phospholipid chain up into that inner membrane space. And that's where we start accumulating all those positive charges. All those protons end up at the very top in that inner membrane space. And that's going to be essential for the last phase. So let's see how that looks. You can see the 2 electrons in the complex 1 move up and out. It will energize. It moves those electrons and transfers them to coenzyme Q. The same thing will happen to complex 2's electrons. It also transfers to coenzyme Q, and they basically share this mediary point. Now we're set and we're primed. The hydrogen now will move up through complex 1 because, again, remember, as the electrons move up, it allows for that gate to open. Hydrogen moves up into that inner membrane space. And you're going to see this electron basically jump across these points. Those 2 FADHs that move the electron into complex 2 moves it to coenzyme Q. That's where that section stops. What you're going to see now is coenzyme Q moving electrons then to complex 3. Same thing happens now that we have complex 3 charged electrons. As that electron moves out, it opens a gate. Hydrogen moves up through that phospholipid chain into that inner membrane space, and it continues all the way across until we have completed complex 1 through complex 4. And notice now we have all these hydrogens, all these protons in the inner membrane space. Well, what happens at this point? Well, the first thing that happens is, as I said, hydrogen ions need to be consumed, and that is where oxygen comes in. So what you first see is atomic oxygen. Atomic oxygen is a half of an O2 molecule. And notice you have 2 hydrogens. And what's going to happen is complex 4 here in this blue is going to donate its electron. That electron moves down. It attaches to that atomic oxygen, those 2 hydrogen, and it forms water. Very, very important key piece in this whole process. And then we have ATP synthase. ATP synthase is essentially taking adenosine diphosphate. You can see down here in this green area, that is basically called a rotor. And I want you to imagine you have this spindle, and that rotor is at the very base where that adenosine diphosphate and phosphorus sits. They sit on a beta group. The hydrogen is now supercharged up in this inner membrane space, and it's going to power this rotor and turn this rotor. And as the hydrogen moves down through that ATP synthesis pump, it spins the rotor. And I want you to imagine if I had adenosine diphosphate on my pinky and I had phosphorus on my thumb. As that rotor turns, it pulls like a magnet the adenosine diphosphate and the phosphorus together to form ATP. And that's constantly happening over and over and over. Now, if you think back at the very beginning, we started with a simple glucose molecule that moved to pyruvate, and we went all the way through this phase. So why is it important to understand this concept? If we go all the way back, guys, to really this area here, where we have the cytochrome C oxidase, and we see that electron getting moved to complex 3. Complex 3 moves to cytochrome C oxidase. Cytochrome C oxidase moves it to complex 4, which then charges complex 4. Hydrogen moves up. Okay. Well, let's use cyanide as an example. Cyanide is one aspect of what's called an uncoupler of oxidative phosphorylation. And there are multiple medications, carbon monoxide, aspirin. There's a lot of substances out there, gases out there that affect those different complexes and uncouple oxidative phosphorylation. So as you can see, we won't have any of the electron moving and being donated to that atomic oxygen and hydrogen to form water without cytochrome C oxidase. If cytochrome C oxidase is not there, then there's no electron being transferred to this complex 4. And if there's no electron transferred to complex 4, no electron can be donated to that atomic oxygen and hydrogen. So that's how cyanide blocks oxidative phosphorylation. It blocks cytochrome C oxidase from donating those electrons. And that's how you can have a patient that is perfectly oxygenated, but at the point where that cytochrome C oxidase donates its electron to complex 4, it blocks that, and now you have cellular death because no ATP can be generated. And because hydrogen is that dominant proton, it's acidic. Imagine from a cell standpoint, the amount of acid accumulation. Think about all the protons on this slide. That is going to cause a severe acidemia within the cell, and the cell will die. That's why we have to understand it to this level, is because we have to understand, well, what is the antidote, for example, for cyanide toxicity? It is actually a B vitamin called hydroxycobalamin. And if you go back to the very beginning of this slide, what facilitated hydrogen moving from the Krebs cycle to the electron transport chain was 2 different B vitamins, niacin and riboflavin. So hopefully, guys, this helps. We end up producing a total of 38 ATP through glycolysis, the Krebs cycle. Remember, that is called substrate phosphorylation without oxygen. Remember, you burn through 2 of those ATP in the first glycolysis phase. We produce 34 more ATP in the electron transport chain, moving those 6 NADHs and 2 FADHs through these complexes. Ultimately, because we burn through 2 of them in that first phase, our net result is 36 ATP. Now that we went over oxidative phosphorylation from the standpoint of really how it works, how does aspirin play into that? I touched on how cyanide blocks this process. It blocks that cytochrome C oxidase from donating the electron to complex 4. Well, how does aspirin do that? Well, aspirin is going to basically be a really effective proton carrier. And so that salicylic acid is going to be up in that inner membrane space. And it's going to attach to hydrogen ions. So it's a great proton carrier. And you're going to have basically that salicylic acid is able to move down into that myocardial matrix. And so it removes the hydrogen. Remember, the hydrogen moved up through that matrix, through the complexes of 1, complex 3, and complex 4. And we have to have a really high positive charge up in that inner membrane space, and that's what's going to drive ATP synthase. Well, if we start removing hydrogen, if the salicylic acid moves hydrogen back down to the myocardial matrix, the hydrogen is not contributing to ATP production, and that hydrogen again has to dissipate. It's got to release its energy, and so it does that in the form of a thermogenic or thermodynamic response, and that's what again drives up our temperature. But the bigger picture, guys, is we have less ATP being formed. Our cells do not have the same energy source, and that is going to play a toll over time. So big picture, those thermodynamics are in play. The hydrogen is going to want to dissipate and release its energy. That's all because of the aspirin grabbing onto and really allowing hydrogen leaking back towards that myocardial matrix. It does not then contribute to ATP production. We said that for every hydrogen, you end up with 1 ATP, and that is going to produce that heat. Another reason why we become hyperthermic, it's not all about the hydrogen leak. It's really a hypermetabolic response. The metabolism is in overdrive. That is also based on that neurotoxicity that is causing that medulla response, causing the increased respiratory rate, increased heart rate. And it really is triggering on those thermosensitive neurons within the brain. If we go back to our pathophysiology slide and we remember we talked about hyperkalemia, that a normal response in acidemia, especially more severe acidemia, is, the more hydrogen that shifts into the cell, more K gets kicked out. And so you should always expect a hyper K state. Well, in this situation, even though she is acidotic, remember a pH of 7.22, we got to remember the vomiting is what is inducing this hypokalemia, right? She's losing K through that vomiting phenomenon. And so that is a big deal that has to be addressed and has to be fixed. And that segues to really those other electrolytes. And we'll come back to that hypokalemia and why it is essential to treat. But as we said, the hypernatremia that we saw in the lab, why are they hypernatremic? Why do they have such large volume losses? And it's because of the fast respiratory rate. Think about the amount of evaporation you have from breathing fast. That's one of the ways that we cool ourselves off. That's definitely as a result of that hyperthermic response. And you also have sweating, that diaphoresis, and that causes free water loss. So that is why. So if we focus more on our understanding of that hypernatremia and how is that a pseudo hypernatremia, let's look at this from the perspective of patient has total sodium loss, even though the lab is showing a hypernatremic state. That's any sodium greater than 145. In the picture here I have on the left, a normal sodium range is 135 to 145 milliequivalents per liter. And we know that that is just based on a solute versus solution based on a percentage. And that's what this picture is showing you. And if we go to the picture on the right, again, anything greater than 145, only thing I've done here is I've shrunk down that volume. So a hypernatremia could simply be based on, hey, we have a depleted amount of volume. The sodium concentration is unchanged. But what I want to really focus on is this. Now we have the picture on the left. That is that hypernatremic situation, right? We have a decreased amount of volume. Sodium level has not changed. Well, what about the picture on the right? Notice the picture on the right, we have actual sodium loss despite that hypernatremic lab. And that's where essentially you see this, right? The volume had already dropped, right? We have a volume loss, but the sodium concentration also dropped. And because we're talking about ratios, the lab still could be greater than 145, but you've actually lost sodium. But you've lost enough volume as well to still have the lab show hypernatremia. And hopefully that makes sense. So we have to be very, very careful. This is nothing that you're going to treat from a standpoint of 3% normal saline or aggressive. You're not going to give anything like that. You're just going to give normal volume, normal saline. And we're always look at a hypernatremia as a volume issue. I mean, that's probably the easiest way to look at it. So we're going to replace that volume. We're not going to be as aggressive as we probably would be in certain circumstances. And I think when you look at medicine overall, we've learned that maybe less is better. So you're only going to do 10 to 20 mils per kilo, but you're going to titrate that volume simply based on a urine output. And notice that urine output is higher. It's 1 to 1.5 mils per kilo per hour. And that's, if you think about burn patients, you think about rhabdo, that's up in the rhabdo range. And so we definitely want a good urine output. So how are we going to treat this patient? How are we going to really focus our ongoing assessment? From an airway standpoint, we always focus on 3 key areas. And I want to start here because that is really something we should always have as a foundation, right? Are they following your commands? Remember, if Glasgow Coma Scale is 13 or 14, she's following your commands. She just might be a little slow. She might not be opening her eyes. And so that is not very alarming to me. Is she able to control her secretions? We should be having her in a semi-Fowler position at all times. Clinical course. What is her clinical course? Those are the 3 areas we always evaluate to determine if we're going to intubate our patient, right? We don't use any more GCS lithinate. We don't use those old methods. But when we think about airway management in aspirin overdose, we have to take it a step further. And really, the one indication that you really want to focus on is, are you seeing hypoventilation? Are you seeing that CO2 increase? That really is the indication they need to be intubated. And so the point is try not to intubate these patients. Absolutely, if you do not have to, the only reason would be, right, they are not moving volume, right? Their end tidal is coming up. You notice that on an ABG. That's going to cause a drop further in pH, and that is significant. If you do determine that you need to intubate, I would definitely be aggressive with buffering. I would give a couple amps of sodium bicarb. And remember, you've got to match that minute ventilation. Whatever that minute ventilation was prior to her being put down for intubation, you've got to match that, and you've got to be aggressive. The key is, when you look at the data and the past cases, there's a huge amount of patients that actually have passed away shortly after intubation. And it comes down to, was there buffering? Did it need to happen? Was the minute ventilation matched to the extent that it needs? And so the lessons come back to, hey, stay away from it if you can. Really, really, even if they're unresponsive, if they're still moving enough air and they're still really driving that metaventilation, and you notice that those CO2s are staying where they're at, it's probably best to just watch the patient and allow them to compensate. As we said earlier, activated charcoal, even if you have a long ingestion time, it's always best in these patients to start activated charcoal. Even, 3-4 hours after ingestion, that absorption happens very, very slowly. So we have to be very diligent and don't be afraid to give it. As we alluded to earlier, and I've touched on a few slides, one of the biggest aspects is to understand the driving force to keep pH levels on the higher end. As we saw, her ABG, she has a pH of 7.22, and I said that's an ominous thing. And it's because when you look at salicylic acid, the pH is right around 6.5. And you look at blood pH, we know a normal pH is 7.4. And not to get into, biochemistry and stuff like that, but really you have to understand the ability for that drug to pass across that membrane, the blood-brain barrier, and into the cells is determined based on really a gradient. And when you think about blood pH and you think about salicylic acid, the lower our blood pH moves, and if you said that salicylic acid pH is 6.5, if the pH starts dropping closer to that pH of the aspirin, you have a massive, massive corresponding increase of aspirin crossing the blood-brain barrier into all of our cells within our heart, our liver, and our brain. And that's what kills our patients, right? So the key here is we want to alkalize these patients. We want to drive that pH to 7.4, even to 7.5. They caution going above 7.5, but mildly alkalotic is absolutely appropriate. And so when you look at her pH of 7.22, she is in a critical situation right now, right? More and more of that aspirin is being able to cross into those cells, which is going to cause a poor outcome. So expanding on the metabolic disorder, we have to understand our urine pH and how that plays into ultimate clearance of that aspirin, right? We want to be able to eliminate that, get it out of the system as quickly as possible. That's one reason why we want to really have a higher urine output. But we have to understand urine pH versus blood pH. And if the urine pH is less than blood pH, right, urine pH range is much wider, but if that pH is greater than blood pH, and that is often the case, right? The urine becomes very, very acidic. And so it's all about, the sodium bicarb is going to be about alkalizing that urine. If we don't alkalize the urine, the acid elimination, the clearance is significantly reduced. And just a quick example, if you increase urine pH from 6.1 all the way to 8.1, you actually increase clearance by 18 times. And so it is super, super essential to understand that. But there's one factor that we haven't really discussed, or I haven't really expanded on, is how does the hypokalemia play into alkalizing this urine? Remember, we have a hypo-K state because of the vomiting. We need to treat that hypo-K state, and that is the key. And we need to do that before we ever give our sodium bicarb to alkalize the urine. So why did the hypo-K start? Well, remember, the vomiting caused us to lose potassium. So we definitely need to increase that K level. So we need to give IV potassium. But the key is to understand, we need to make sure we understand that that is going to really play into how our urine is able to become alkalized. So before we ever give any sodium bicarb, we have to increase the K. So our goal is to increase that K to a point where we reach 4 or greater. So why is that? Well, remember, the kidneys really are in an influx state. They're struggling. Our body identifies that our K is low, right? We're in that hypokalemia. So what it does is it holds on to K. It doesn't want to get rid of it. But it's still, the urine basically can't tell the difference between the K and the hydrogen ion. And so it excretes the hydrogen ion. And by doing that, that causes the urine to become more acidotic. And so by giving sodium bicarb, really, without fixing the potassium, you're just neutralizing the urine. You're not alkalizing the urine, you're neutralizing it. And we can only alkalize the urine if we first fix the hypo-K state. So that is super, super imperative. And that goes back to, if we're alkalizing the urine, that's going to cause our body to also, it's going to affect our metabolic side. And as we showed a few slides before, it's all about bringing that pH up into that normal 7.4 or 7.5 range, not to exceed 7.5, because that widens the gradient and we have less aspirin, less salicylic acid moving across into the brain, into the heart, into the liver, into those cells. And that is the key. That's where you really start seeing the decline in your patient. So when we look at alkalization from just a big picture, we always want to evaluate, have we fixed the potassium? Do we have a K greater than 4? What's our pH? Is our pH less than 7.4? Remember, we want to get it up to that 7.4 or greater, again, not to exceed 7.5. And the last thing is the aspirin level less than 40 milligrams per deciliter? If you could say yes, then you're going to start a bicarb drip, right? And a great way is to use 3 amps of bicarb in D5W, run it at 1.5 to 2 times maintenance rate. Again, you'll have to determine what maintenance rate really is in your shop, in your guidelines. I've asked multiple people what their maintenance rate is or what's their perspective on maintenance rate. This is just one recommendation. The other side of this algorithm, though, is really, hey, if this situation is a little bit more, aspirin levels are higher, right? Your aspirin level is not less than 40, then maybe it's warranted to bolus them with some bicarb. And so 1 to 2 milliequivalents per kilo of sodium bicarb to really buffer and get them moving towards that 7.4 range. Now let's look at reassessment and really kind of bring this home. What happened to this patient? How did this patient do? Well, at 8 hours, aspirin levels, as you can see, skyrocketed to 486. ABG trended down. pH, as you can see, 7.03. CO2 at 19. Bicarb is less than 10. And that is an ominous finding. And so we're still in that partially compensated metabolic acidosis. Notice there's no hypoxemia. Anon gap has increased from 24 to 36. So definitely going in the wrong direction in this patient. One of those pearls that I always like to add is there are some key areas, right? If you have a high anon gap, you are in a metabolic acidosis, right? And you notice that your bicarb is less than 10, that is always a red flag for a toxicity. So always think about that. You could also add a lactate that's super off the charts. Like we're not talking, single digits, we're talking double digits. That should lead you down the road of some type of toxicity. So based on that, really the patient continued to decline and passed away about an hour later. And that is the sad realization of a case like this. 33 years old, very healthy, right? If ingestion is not identified early, right, we go a long period, treatment pathway ends up going down, really the sepsis guidelines. So you really miss a lot of opportunities, a lot of core areas that we've touched on that really have to be addressed, that have to be identified early and started early for these patients to start trending in the right way. The lower we allow that pH to drop, the worse these patients get. The more aspirin, the more salicylic acid moves into the cells, and that neurotoxicity, that toxicity to the heart and the liver really start increasing. And that's the unfortunate side. In summary, always have a high index of suspicion for any potential patient with a SIRS-like response. Even if you don't know there's an aspirin ingestion or toxicity, just have that in the back of your mind. These patients obviously are very complex, and they're going to greatly benefit from early recognition. Don't forget activated charcoal. I know it's not fun to give. If you can get your patient to drink it, I was always pretty good at getting my patients to drink it. If I can get them to drink it, then that's going to be much better. Remember, uncoupling of oxidative phosphorylation, even though from an explanation standpoint, it's very complex, it's a huge, huge part of this problem. And we have to understand how those electrons get transferred through those 4 complexes, ultimately to charge that system and allow that electron to be donated to that atomic oxygen. That's how we build water. And we know water is really what drives a lot of our body processes. That's the big fuel source that we need. But those hydrogens up in that inner membrane space have to be brought down through that ATP synthase pump to drive that turbine that brings adenosine diphosphate and phosphorus together to form ATP. And that's where our mitochondria pulls that energy from. If we have high aspirin levels, remember that aspirin then is a proton carrier, is able to move protons from that inner membrane space back to the matrix area. That reduces that charge in that upper area, that inner membrane space, which also reduces the amount of hydrogen that can be used for ATP production. And that's one big problem, but also the hydrogen dissipates and forms energy, forms heat. That worsens that neurotoxicity that you're seeing also drive up the temperature. Worsening acidemia is ominous, right? Greatest impact to salicylic acid transfer into the cell. Got to alkalize not only the blood, but the urine. Treating the hypokalemia has to be done prior to any urine alkalization, or you're just neutralizing the urine. You're not truly alkalizing. And remember airway management, right? Especially from the pre-hospital standpoint, we're very, very diligent and taught to really watch the airway and use the 3 areas that we talked about. Can they follow commands? Can they control secretions? And what their clinical course? This is definitely one of those areas that the outcomes are much worse when these patients are intubated. So always keep that in the back of your mind.
That's going to wrap up this podcast. If you have any questions, as always, please email me, eric.bauer@FlightBridgeED.com. If you have any ideas or great cases that you've recently had or come across, please let us know, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.